And without further ado, Patient-Centered Care, an introduction to cancer registry operations with Isaiah Zipple, CTR. Isaiah Zipple has a BS in Biology and Health Sciences from Duquesne University. He has worked as a certified tumor registrar since September 2015 in a team lead role since August 2020. He is also the chair of the nominating committee for the Association of NC Central Cancer Registries. Isaiah, welcome. Are you able to hear us? And I'm not sure if we're able to see you yet.
Yes, I think you'll be able to hear me. I think that we'll only be able to stick with audio for now.
All right. Well, we're sorry that the video isn't working, but we are very, very pleased to have you here today. In addition to the professional information that I just shared with our audience, I learned in speaking with you the other day that our wives work together, and that was interesting, and that your uncle builds guitars and sells them in part through a music store that I used to work at in Michigan many lifetimes ago. So those were fun things for me to learn. What's something else that we should know about you outside of your professional bio?
Well, I have two dogs. One is a pit bull mix, and the other one is a Shih Tzu. So if you hear any snoring sounds, it's just that my dogs don't find the cancer registry information as interesting as I do.
All right. Well, we'll keep that in mind. That's great. Thank you so much. I mentioned a minute ago that, whoops, and I advanced through the slides too quickly. We will be using poll everywhere. This is the first question. Cancer registry data is used by researchers, healthcare providers, and public health officials to better monitor and advance cancer treatments, prevention, research, and screening programs. So in a minute, you'll have the opportunity to let us know if you think that's true or false. I've got a disclosure to share, a few of them. This activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Professional Development, Continuing Professional Development. The course director and CPD staff have no financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina, Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. A potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which he, she, they has a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with commercial interests pertaining to this activity. All righty, let's take a look at that poll everywhere. And there we go. Perfect. Thank you. So we've 100% true so far. Isaiah, let's give our audience a few more seconds to respond to that. It looks very solidly in the A or true category. How are they doing?
They're doing great.
Awesome. So those are all true. Intro to Cancer Registry Operations, Isaiah Zipple, CTR Team Lead, UNC Healthcare. And I'll leave it to you, Isaiah. Are you able to advance the slides? Is that working for you?
Yes, it is.
Perfect. All right. Thank you so much.
Thanks, Tim. So to give a bit of background about our cancer registry, we have 8 CTRs. We have one administrative associate that helps us with rapid case ascertainment, along with case finding. Case finding helps us know what cases are relevant for inclusion within our cancer registry. And then we have 2 admins that work exclusively on follow-up. Follow-up consists of collecting follow-up information on patients that have a history of cancer at UNC. We'll go into this more and more detail later, but we actually collect follow-up information for the life of the patient. So it's quite an extensive task collecting all of that follow-up information. We collect cancer registry data for a number of facilities outside of UNC Medical Center in Chapel Hill. Depending on the years we're talking about, we collect data for McCreary Cancer Center. In addition, we also collect data on Rockingham Cancer Center. In the past, we also used to collect information for Hayworth. And so there are certain years where when we talk about what facilities we collect for, it's really important to know which facilities we're talking about. There are instances where we will perform data requests. So one of the first things that I'll ask when somebody sends a data request to their cancer registry, one of the first things I'll always clarify is, what facilities are you interested in receiving this report on? So who do we report to? The cancer registry at UNC, we supply information to a number of different entities. Firstly, we report data to hospital administration. Hospital administration will use our data for planning and kind of monitoring how many patient case volumes for upcoming years and historical trends. We also submit quarterly to the North Carolina Central Cancer Registry. Central Registry will then take abstracts from all the different hospitals that have submitted abstracts for a single patient. They will then reconcile any differences between them to come up with a single abstract per individual. In addition to the Central Cancer Registry, we submit the NCDB. That is on an annual basis. I believe that they are moving in the direction of rolling submissions to kind of decrease the burden on just a single submission at a time. We were lucky enough to participate in a pilot program, and when we were looking at this program, it was interested in patients with non-small cell lung carcinomas that were diagnosed between 2017 and 2018 that had stage 3B to 4B cancer. And part of this program, they were trying to identify the utility of different data items that were going to be new. So we re-abstracted these cases with these new data items for inclusion. And it was just really interesting to be part of something that might impact exactly what is included in registry data collection. So what is reportable in the cancer registry? We collect data on all malignancies. So if the histology for the cancer ends in a /2, which is the behavior code, /2 indicates in situ, a /3 indicates invasive. We report all in situ and invasive tumors. There are a couple exceptions to this. We won't go into all of them, but the most notable exceptions are basal and squamous cell carcinomas of the skin. The reason for this is that we really already have a good understanding of what causes these malignancies. We know that it's caused by some exposure. The other part of that is if we collected every single basal and squamous cell carcinoma of the skin, it would be all we did. We don't have the capacity. Every registry in the country would spend the majority of their time on just one primer. It is a huge volume It used to be that we would collect data if there was nodal invasion, but that has since been discontinued for basal and squamous cell of the skin. We also collect non-malignant tumors of the brain and central nervous system. So these are going to be your meningiomas, schwannomas, any benign brain tumor we will be collecting. We also collect reportable by agreement cases. The Central Cancer Registry dictates what cases are reportable by agreement. For the state of North Carolina, we are required to collect certain sites that have high-grade intraepithelial neoplasia. These are things like VIN3, VAIN3, AIN3, LIN3, and SIN3. And as of the 1st of 2022, we also collect adenomatous polyps with high-grade dysplasia of the stomach and small intestine. This is a new thing that the Central Registry is having us collect. And it's just another example of reportable by agreement. So now that we know what types of tumors the Cancer Registry collects, what information do we collect for every patient? I'm going to take some time to go over this slide because I think it's going to be the most useful to better understand what it is that the Cancer Registry collects. So we can kind of break down what we collect into demographics, diagnostic information, staging, treatment, and outcomes. With demographics, we'll collect things like name, social security number, medical record number, address, and with address, we collect not only address at time of diagnosis, but also the patient's current address. And that is updated as part of our follow-up process. We collect race, ethnicity, and risk factors like tobacco and alcohol and family history of cancer. We'll try to identify occupation. Certain occupations are certainly at a higher risk for cancers. I think we have a comment that says that they lost audio. Can someone comment if they're hearing audio?
We do have audio here.
Okay.
So I think that, thank you. I'm sorry that you've lost, for the individual who lost audio. I do believe this is isolated, and please go ahead and reach out at 919-445-1000. I'll put that in the chat because they're probably not hearing me, but hopefully this is isolated, but do let us know on the chat if you are losing audio as well. Thank you. Isaiah, yeah, I think you're good to keep moving forward, but I think most of us are getting the audio. Thank you.
Okay. With occupation, there are certainly some occupations that have extremely high risk of cancers. One notable example would be dry cleaning. There are really high rates of sarcomas in this profession with some of the chemicals that they use, and long-term exposure. It is not uncommon to see quite unusual histologies and presentations. We do try to collect birth state and country. It can be quite difficult. That this is not always collected in the medical record. It's quite commonly, when we find it, it will be in a patient's obituary. So when we have the information, we do try to collect that. Under diagnostic information, this is going to go into when they were diagnosed, the date of diagnosis, when they presented to UNC, where they were diagnosed, comorbidities that they had at diagnosis. Histology, what type of cancer are we talking about? What is the primary site? How was this diagnosed? With diagnostic confirmation, that's going to be looking at was this patient diagnosed by a biopsy? Do we have histologic confirmation? Was it diagnosed only by something like cytology? Is the only histology information we have based on a fine needle aspiration? It will also look at things like imaging. Sometimes we only have our diagnosis might be made by a combination of things like imaging with a tumor marker study. So that's what that field is going to be looking at. Importantly, we do look at insurance at diagnosis. Because UNC is a public institution that is a comprehensive cancer center, we see diagnoses that other institutions may not. And we will see folks that do not have insurance. So it's really important for studies to know a patient's insurance status, specifically when they were diagnosed. For the years 2020 and 2021, we have fields of COVID-19 testing. We also collected for 2022, but it's not required by the NCDB, but we still collect it for the state. This field looks at if a patient was diagnosed with COVID, specifically when they tested positive, and if their positive COVID test had an impact on delays in care. I think one of the difficulties with this COVID field is it doesn't take into account things like personal choices that people took during the pandemic as it relates to their care. It's very hard to say if a patient delayed a screening test for cancer because they didn't want to go into the office because they were having symptoms. So it doesn't really do a great job at establishing these less explicit statements that impact individuals' behavior. But we do record if we know that the patient tested positive and if there was kind of these explicit statements of that they're going to not receive radiation or something like that because of fear of COVID. We also document which physicians are treating different patients. Staging. There are some primaries where we have really great documentation by our physicians of clinical and pathologic staging, and that's extremely helpful. We include a clinical and either a pathologic stage or a post-treatment stage for every primary. And that includes TNM staging for all sites. Some sites aren't going to have a specific schema and staging associated with them, but we will include it based on imaging and physician statements to come up with a comprehensive stage. Treatment. I'll go into this more on another slide, but briefly, we collect information on surgery, radiation, any systemic drugs like chemo, hormone, and immunotherapies given before or after surgery. We also include any palliative treatment that is performed. Under outcomes, I know I mentioned this briefly earlier, but we collect information on an annual basis, well, once every 15 months on patient outcomes. And this includes vital status, cancer status, and if a patient does pass away, it also includes things like date of death. If cancer was included on their death certificate, we list it as a contributing factor. and where the patient was deceased. So when we talk about cases inside the cancer registry, an important part of that is the class of case. We can break down cases into both analytic and non-analytic cases. Analytic cases are going to be cases that were diagnosed or part of their treatment was at UNC. Depending on the combination of those factors, we'll assign a code that incorporates those different attributes. For non-analytic cases, that is when a patient presents to UNC with either recurrent or persistent disease, or when UNC was part of the diagnostic workup. There's also a third category not listed here, which describes when a patient has a pathology that is submitted to UNC for interpretation, and that's the only part of their care that is performed here. So this slide is looking at case volumes that the cancer registry performs per year. Since 2014, we have had year-over-year growth with increases in the number of cases, with the exception being of when COVID started. In 2020, we did see about a 14% decrease in our case volume. And that is not unique to UNC. According to the central registry, that number is in keeping with other facilities of our size. We have seen an increase in 2021 cases, but they're still not quite back to pre-pandemic levels. So it'll be, I'm sure that there will be a huge amount of research coming up in the years following COVID, looking at stage of presentation. I think is going to be a huge factor in terms of research that's performed. I do worry that things like screening procedures on an outpatient basis are happening less frequently because folks are hesitant to come in, and they might be delaying care for symptoms that they would normally present to a physician for. So keeping case volumes in mind as we move forward, and the stage of presentation will be an important factor, in the years to come. So we collect, the cancer registry is primarily focused on first course treatment. First course treatment is basically all of the treatment that is performed before the patient has progression of disease. Importantly, and this quote is directly from the STORE manual, and the STORE manual stands for Standards for Oncology Registry Entry. So you can see why we stick with STORE. The first course of treatment also includes things like maintenance therapy. Some examples of this would be when a patient is given hormone therapy for breast cancer. If it's part of their first course treatment, a patient might have all of their surgery, chemo, radiation at an outside facility. They're put on maintenance hormone therapy, and the plan is to do that for 5 years. They then present to UNC 2 years into their 5 years, and they continue that same hormone therapy. That maintenance therapy that UNC prescribes and continues is still considered part of the first course treatment. Another example of this would be Synthroid when it is given for thyroid cancer. So first course of treatment, we collect all treatment, whether it is provided at UNC or at outside facilities for analytic cases. It's part of a registrar's job to make sure that we collect all information, regardless of where it was provided. And if we're missing information, that we request that information from outside facilities. A fairly common example of this is going to be if a patient has radiation performed locally. Because we're a comprehensive center, patients sometimes travel quite far to receive care. And it's just not, most patients don't want to travel 2 hours every day to receive radiation. So they might just receive radiation closer to home. That's a fairly common thing that we do see. But we will need to request that information if it's provided at an outside facility and we do not have access to the details. Advances in technology have really decreased how much we have to submit those types of requests. Care Everywhere has been really extremely helpful at obtaining outside information, so we don't need to necessarily make those requests. It's really quite amazing how much information one can find in Care Everywhere that can be made available. It's merely a matter of sorting through the details, and some facilities are also very good at submitting external documents to us that we also review. So treatment modalities, when we're talking about cancer treatment, we commonly treat with surgery. Physical descriptions of the surgeries that are performed are unique to the primary site. Descriptions, very detailed descriptions of what these surgeries entail are part of the STOR manual in Appendix A. Chemotherapy, I'm going to kind of group chemo, immunotherapy, and hormone therapy for this next statement, but I can't keep all of those drugs straight. I don't know what classification different things of chemo are necessarily off the top of my head. And to free up brain space, we have a website that cancer registrars will commonly use. That CRX differentiates how different drugs should be coded. So if it's chemotherapy, it'll tell you that it gives treatment regimens and what those regimens are used for. And it will differentiate what those drugs are coded as in our registry software. So with chemo, we can differentiate between a single agent being given or multiple agents being given. And we can also indicate if a patient refuses treatment. With radiation, we can collect things like dates that a patient undergoes radiation. We'll go more into the specifics on radiation because if we have folks from radiation on the call, I think it's really helpful to understand what registrars are required to put in. We will also collect information on immunotherapy, hormone therapy. If a patient undergoes something like a stem cell transplant, we do collect that information. Other treatments, we'll collect information on if a patient is undergoing a clinical trial. There isn't a great way of identifying specifically which clinical trial the patient is enlisted in. And there's a number of clinical trials that will not be represented in the registry. The clinical trials are unique to cancer treatment, and if a patient is enrolled in a clinical trial that may not be part of specifically cancer treatment, it will not be part of what we collect. Palliative care, we do collect, and it includes things like if a patient receives palliative chemotherapy or other systemic drugs, radiation, pain management, or a combination of those different items. So when we talk about radiation, there's quite a bit that registrars collect. We collect information like the date it was started, and each of these are broken down into phases. So if a patient undergoes a primary phase of radiation followed by a boost, we collect the dates of both phases. What the treatment volume is, if nodes are irradiated, what modality is selected. Is this going to be external beam therapy? Is it going to be brachytherapy? Planning techniques. So this is either going to be IMRT, 3D, things like that, that is planning technique. And all of this is usually contained within the initial radiation consult note. Number of fractions. How many fractions are delivered to the primary site? And what is the dosage of each fraction? We do have physicians that are extremely good at utilizing, there is a radiation documentation summary tab note in Epic. And we really, really appreciate when physicians use that. It makes our job a lot easier for collecting this information. If we can teach residents anything, it is that this note exists and how to use it, because it really nicely captures the history of radiation at UNC, and it will be something that we need to collect. Oh, and I did include a note at the bottom. If anyone has more specific interest on radiation and how CTRs need to collect that, there is a CTR guide to coding radiation therapy, and that is available online, and it's a PDF, and it goes through kind of case examples of how different situations would be coded. And I found it really quite useful to have real examples about what is collected and how to code things appropriately. So I know I mentioned this earlier, but first course of treatment is going to stop when there is disease progression or recurrence. This is really important for a number of reasons. The primary reason is that we are primarily interested in first course of treatment information. So when there's progression and it is subsequent therapy, there's not necessarily a guarantee that it's going to be housed within the cancer registry. Certain treatment modalities are kind of reserved for when patients have more advanced disease or they do have progression. So CAR T therapy, for example, sometimes immunotherapies might be reserved for progression. So if you are looking at the data and we have lower rates of certain therapies, that's something to keep in mind, is that we are primarily concerned with first course of treatment before there is disease progression. Tumor recurrence. So there's kind of differences in the ways that physicians will use the word recurrence and the way that registries make that determination. There's kind of a general understanding that when physicians use the word recurrence, it kind of means that their cancer came back. That's not how registries view the word recurrence. We have very standardized rules as to what constitutes a recurrence. There are specific timelines as to when a patient had their original cancer and when this recurrence occurred to determine how many primaries. If a patient has a recurrence and is outside of that timeline, it may be counted as a second primary. We have rules that are broken down by site for the following locations, and that's head and neck, colon, melanoma, lung, breast, kidney, urinary sites, malignant brain tumors, and benign brain tumors. Anything that is not in those sites falls into a catch-all of other sites. Previous iteration, we currently go by the solid tumor rules when making this determination. Previously, we had been using the multiple primary and histology rules. These rules were updated in 2018 when we moved to AJCC 8th edition. There are some differences between those two sets of rules. One example that is notable is brain tumors. Prior to 2018, if you had bilateral meningiomas, the cancer registry would abstract two primaries because that's what the multiple primary rules dictated at the time. When you move past 2018, the solid tumor rules would tell you that is a single primary. So there are some slight differences between years in terms of counting the number of primaries and recurrence rules. So I think we have a poll everywhere question. And so the question is, what sources can cancer registries utilize for case finding?
All right. And if your screen is a little small or anything like that, I'll just let you know A is EMR reporting, B is pathology reports, C is imaging, and D is all of the above. So let's take about 10 more seconds. While we're waiting, I want to remind everyone that there'll be an opportunity for you to share your questions with Isaiah at the end. Isaiah, this is amazing. I've got a list of questions that's going to go way past what we have time for, and I know others are compiling ones as well, but this is just fascinating. Looks like they're landing on D, all of the above. How are they doing?
They're doing great. Yes, we do use all of these sources of information when we are doing case finding. So we'll use business objects that reports out of Epic, which is a large source of our reporting in the EMR. We look at path reports, we look at imaging. So all of these make really good sources of information. When we talk about case finding is both an active and a passive process. When we look at reporting out of Epic, that's fairly passive. It looks at cancer codes recorded in the EMR, and it then can be merged directly with our cancer registry software. But that is kind of not quite enough for what all we have to look at. We also look at path reports. We'll look at imaging. We'll go into a kind of a case study of this in a little bit, but we do use all those sources. So I'm going to be very interested to see what folks on the call, how they answered this one. But I'll read out the options. When we do not have a biopsy or a histologic confirmation of a tumor, which of the following ambiguous terms counts as a cancer diagnosis? So we have an 80 chance of malignancy, a LERADS 5 lesion of the liver, comparable with adenocarcinoma, or suspect renal cell neoplasm.
All right, we're getting a lot of variation on the answers, and this is definitely a tough one. And this is not one of these all of the above questions. All right, Isaiah, how are they doing?
So I'm not surprised that there's kind of this variation, because for many folks, at least B, B as in boy, LERADS 5 lesion, if you read the imaging report, LERADS 5, if you look at imaging at the bottom of the impression, it will say this is definitely hepatocellular carcinoma. From a cancer registry perspective, this is not enough to independently say that this is liver cancer. That it requires additional physician statements that the imaging represents cancer. So the correct answer is going to be C. Suspect renal cell neoplasm was also commonly answered. Neoplasm by itself doesn't count unless we're talking about a brain tumor. Neoplasm is not a diagnostic term. So moving on to ambiguous terminology. These are the words that do constitute a diagnosis. Importantly, let's think about what is not listed here. Highly concerning, you will not see on this list. Concerning, a modifier, concerning and highly concerning are both not on this list. Differential diagnosis is not on this list. So there are kind of differences of what one might have for a clinician might say, and they might have an understanding that this tumor is cancer. Whereas a cancer registrar has a different understanding. So if we can merge those understandings, I think that's helpful. So these are the diagnostic terms that independently of histologic testing would be a diagnosis. Neoplasm only applies to brain tumors. Moving on to terms that do not constitute a diagnosis. So if you have a possible melanoma, that would not be diagnostic. Potentially malignant, also not diagnostic. I wanted to include this slide. Cancer registry data requests. Data requests are either going to come, you can send them directly to me. I've listed my contact information. These are going to be quality improvement projects. And that is different from things that are needed for an IRB proposal. Those are going to go to NC Tracks directly. There's some instructions on how to submit an NC Tracks request. Importantly, both NC Tracks and any requests that are sent to the cancer registry, they utilize the same data. NC Tracks actually uses CR Star, which is our cancer registry software. that we utilize. So regardless of which path you need, the data should be the same. Data request considerations. First course treatment is our primary consideration. So we talked about it previously, the implications for that. Certain treatment modalities will not be collected if they're after disease progression. MRN length, if you need and are interested in specific medical record numbers, historically, we were only able to collect 11 digits. In Epic, that number is 12 digits, so the numbers don't always match directly. We're in the process of updating those, but if you need data from before about 2018, they may not match exactly. There are different fields for AJCC 8th edition. If you need information before 2018, we can discuss the implications of that, but know that the staging is not apples to apples. I think I mentioned this earlier, but one of the first questions I'll ask you if you submit a data request is what facilities would you like to have included? Because we do have different facilities that we collect data on. Also important, there is about a 6-month lag time in terms of when we are collecting and abstracting data. So right now in September, we're abstracting March cases of 2022. And understand that patients have sometimes quite a long treatment regimen. If treatment is going to last 18 months, if you're wanting March 22 cases, they may or may not be done with treatment. So that's important to keep in mind. Depending on the information you're interested in, there might be some site-specific information that we can also provide you with. This is the case study I wanted to go through. We identified that there was a gap in the number of renal cell carcinomas that were a low clinical stage and what we had abstracted in the cancer registry. So what we did is we kind of investigated as to a root cause, and we identified that when patients had imaging done, a physician might include in their note, suspect that this is renal cell carcinoma. The problem was that the only associated diagnosis code for the site visit was N28.89, and that is a code for kidney mass. It doesn't necessarily mean kidney cancer, but based on the physician note, it would be reportable, and they would usually follow it through surveillance. So if anyone from outside registries is on the call, I would encourage you to look at kidney masses to make sure there isn't a physician statement that makes these masses reportable. Our current process requires us to look at all kidney masses, most of which are not reportable, but it does ensure that we have complete reporting on this site. Follow-up information, we briefly touched on this. I know we're running out of time, but we do collect follow-up information for patients. We have to maintain 90% follow-up rates for patients diagnosed in the last 5 years, 80% follow-up rates if they were diagnosed since 2004. And since 2004, we perform currently active follow-up on over 25,000 patients. So it is quite a large volume that we are performing follow-up on. We'll skip this slide. So this is another poll everywhere question. Which of the following are used as sources of follow-up information?
And thank you for all of you who have been engaging with Poll Everywhere and responding to these. Take just about 5 more seconds, if you would, please. Isaiah, how are they doing?
They're doing great. So yeah, all of these are sources that we do utilize when we're performing follow-up. We do rapid case ascertainment. I know we're running out of time. I could go into this in more length, but it is a way to monitor cancer burden instantly in time. Because abstracts take 6 months, there is significant lag time. The state has a vested interest in knowing what is the cancer burden in the state of North Carolina today. And rapid case, we submit those cases to better appreciate what is the true count for certain sites in current time. And these are the studies that are utilizing our CA process.
All right, thank you so much. And you've got references listed, and the slides will be available. And then also the recording and the self-paced online course will be available as well. So we're going ahead and opening it up for questions. Please go ahead and use Poll Everywhere to submit your questions. Looks like we've already got one. Here we go. Great, thank you. Is there a general length of time between cancers that would distinguish the second cancer as a new primary, even if it was the same site histology?
That's going to depend on the primary site. It's kind of specific to that. For things like cancer, it's 3 years. For other sites, it is only 1 year. So for things like intraepithelial neoplasia, which has an extremely high rate of recurrence, if it recurs more than a year later, it's going to be a new primary. So to answer your question is, it depends.
Isaiah, I just lost your audio. I'm not sure. I guess it's possible that it was my audio that went out.
Can you hear me now?
Yes.
Okay. So to answer that question, it depends on what primary site we're talking about. Different primary sites have different timelines that apply. For things like bladder cancer, it's 3 years. For other sites, it might only be 1 year. So it really just depends on where the cancer is occurring. And we really have to utilize those solid tumor rules to establish recurrence information.
Great. Thank you so much. We'll wait for, let's see, we'll need to wrap up soon, but we've got time for a couple of other questions. And while we're waiting to see if others come in, let me ask, I know at the beginning of your talk, you mentioned local and state and national databases. What's being done, if anything, on an international level to compile the data, starting from where it is here does it make it up to any sort of international levels of data?
That I'm less sure of. I know there is some international data collection effort. I know different countries use slightly different methods of collecting, like different staging schemas. So I'm not sure how it compares internationally. I'm just not sure on that.
Sure, that is all right. We do have another question. Do UNC medical school students receive any instruction in the registry process, didactic or rotational? Great question.
That is a great question. I wish they did. I commonly, when we get data requests, we'll go over what we collect, and no one has the idea that we collect this information.
Oh my gosh.
We could incorporate this to medical students. I think that would go a long ways at making sure that moving forward, folks know about it.
That's good to know, and I'll let that be a lead into another question I had on my list, and that's part of it, I think. What would improve your ability to do your work as a CTR?
Um, increased those radiation summary notes in Epic they're fantastic. When we see them, it's great. Um, and there's been a big push to increase folks using them. The other thing is it relates to follow-up. Um, the only way that we can say a patient does not have cancer is if a physician says it. Because of my credentialing, I'm not qualified to say if a patient has cancer or not. So that really has to come from a physician,
Mhm.
kind of to a painful extent. You know, if a patient has melanoma in situ and they have no surgery and the margins are clear after Mohs, uh, unless a physician says this patient is free of cancer, we have to assume that the patient does have cancer.
All right. Thank you so much. Let me check and see if there are any. Yeah, that's all the questions that came in. Thanks to our audience for those questions. And thanks to you, Isaiah, for this presentation. This is the first time we've done this. This has been phenomenal. I think we all learned a lot. So we are very appreciative. And I hope to be able to follow up with you because I still have about 10 questions on my list. And maybe we can talk sometime soon. I want to say thank you to the people of North Carolina for their generous support through their tax dollars of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to say thank you to our team, Naja Brown, John Powell, Pat Muscarella, Benny Obure, Oliver Marth, and Andrew Dodgson for all of their hard work on each and every one of these lectures.